me record this. Really do need to meet with everybody that scored below a 78. Okay, so please reach out to me. I have time slots that I put in your announcements for Saturday, Sunday, and Monday. If we need to move further into next week, we can, but I'd like to try and do it the next 3 days, if we could. Let's see, what else? I've sent you exam 2 study guide. And so we're reviewing weeks 3 and 4 today. So you should have a good chunk of that study guide covered by the end of class today. So I would like for you to go back at some point over the next couple of days while the information is still fresh in your mind, and go back and highlight or go back and mark up your study guide as to what areas we covered today. And that will show you, or that will give you a good indication of what's left to be covered next week, and will hopefully reinforce the lecture information from today. Sorry to interrupt. I just want to let another student in. Pauline. Okay, so just not to get off track here, but I have Kate. I need to know from Kate, Tanisha, and Pauline. Pauline, for exam 1, did you attend a review session or did you watch a recording?
I attended a review session.
And whose did
And
you?
I also watched the recording.
Okay, whose did you attend?
I think yours.
Was it mine? Okay.
Yes, and I watched
Okay.
Blondie, I think it was.
Okay. Tanisha, what about you? Where's Tanisha? There you are. Pardon me?
I was just making sure you were saying my name. I know it's like two Tanishas.
Oh, okay. Did you attend a live session or watch a recording?
No, I actually was in class during those times. I just watched it over.
Okay. Kate, what about you?
I watched 2 recordings, yours and
Great.
Dr.
Lending. Okay.
Yes.
And for you students that are still coming in that are Professor Apple's students, if you could put your name in your campus in the chat so I can provide her with the names of students that attended, I would appreciate that. Okay, so let's see, where were we? Oh, study guide. So you have your study guide. I would appreciate if you would take a look at it, over the next 3 or 4 days. Again, I'll say what I said for exam 1, the study guide is an excellent representation for exam 2 as well. And that's what we're going to be talking about today. Does anybody have any questions? By the way, everybody, for the most part, excellent group projects. Excellent. Very impressed. Really impressed. You guys did a fabulous job. And if your group had some challenging issues with group dynamics, then, learn from what happened as a group and do better the next time. There's a reason we do group projects. Nursing involves teamwork, collaboration, communication, and that's why we want to get you guys working in teams. Okay, nurses work in teams all the time. Got to be able to be a willing participant for group work. Questions? Does anybody have any questions so far? Okay. Let's see. Let's see. I do want to cover the one thing I'm going to cover today at the beginning here. Let me still admit somebody. Okay. All right, the one thing I do want to cover is it's in module 9. Has anybody taken the time to look at your vulnerable populations assignment. Whoops. Anybody taking time to look at your vulnerable populations assignment? That's a yes or no question, please.
I have not yet.
Has anybody taken a look at it? Speak up if you have. I would really appreciate it. Okay,
I
so,
have taken a look at it.
okay, thank you. I need everybody to take a look at it in the next week. Actually, in the next probably 4 or 5 days. Please take a look at it. It is in week 9, module 9, week 9, and that it's in there because that's the week it's due. But this isn't not an assignment that you want to wait till week 8 to do. You're not going to be able to do it because it requires research and getting out in your community and researching a vulnerable population. So I want to discuss this in week 4 and give you a heads up that you should get started with this assignment in the next couple of weeks. So what this is, this is also a good chunk of your grade. This is 8% of your grade, homework grade. Okay, so you need to select a vulnerable population. Here's the most important part: in your own community. Okay, in your zip code. Okay, please, a lot of students got tripped up last term. I need a vulnerable population in your community that you're researching, not the general statistics for homelessness in the United States or substance abuse in the United States. I don't need a general overview of that. I need you to be selecting a population in your own community that you're going to research. Okay, and then you're going to do research about them. Okay, so here, assignment details. This is a PowerPoint. This is a slide presentation. Okay, this is our instructor. Okay, hang on, still admitting people. Okay. Okay, so from the vulnerable population you select, and down a little bit below are suggestions from the textbook for vulnerable populations. If you want to go outside of this list, just let me know. Otherwise, I don't need to know what population you've selected. Try and stay within this list. But if you have a personal interest in doing something else in your community, please let me know. It's fine. So you're going to be identifying your population in detail, and there's more specifics for each of these sections, but here's what you're going to be doing: identifying the vulnerable population in your community in detail, identify health risks and needs of that vulnerable population, resources that are available and those that are needed but it may not be available, service gaps, interventions. And I want those in primary, secondary, and tertiary that could fill gaps. And then summary. It's a PowerPoint, maximum of 10 slides. Please, this is the filing name. I need you to submit it under right here. Okay, here's your vulnerable populations. And then here's specific detail of how you can organize it. Okay. So up top, the first bullet was describe your vulnerable population. Here's 7 areas to describe it with: health risks, health promotion, resources, service gaps listed out in primary, secondary, tertiary. Here's a good start with resources. Okay, but you can go beyond that. I would encourage you to go beyond that. You might need to go beyond that depending on your population. Okay. The one thing I wanted to mention up here, conduct a research on your chosen population via the internet and by calling or visiting your local health department. So you may need to put some feelers out there and visit, if you're doing homeless, you might want to visit a homeless shelter or call a homeless shelter and get information. You're going to need to as you do all the research for this. So like I said, it's not a project that you start in week 8. Okay. You can expand on this, your resources, and then there's 6 areas that you're graded on. Okay, so after you read what the assignment is about, definitely take a look at this rubric and see how it's graded. You should be looking at all the rubrics before you do assignments to see how it's going to be graded. So you can read the rubric. So
I have
everything's
a
right.
quick question.
Yep. Who's speaking?
It's Alyssa Sherman.
Hi, Alyssa.
So my question is, we're in a group project and you said it has to be in a zip code, but some of us are in different areas. It just has
No,
to be in
this-
one of our zip codes.
This isn't this is not a group project.
It's not a group project. Okay,
Nope.
perfect.
Nope, this is an individual project. Your next group project is, and it's not too soon for that either. Is you need to select we're in week 4, so that's going to be coming up. I'll go through that real quick. Does anybody have questions about this assignment?
No,
Okay.
thanks for the information.
Does that help? Yeah. So
Yes,
get-
I put my other population I like to do. I can email it to you as well if you like, Professor Marvel.
if it's not on this list, please email it to me.
Okay.
Yep. I had a couple of students last term go outside of that list and do something that was of interest to them, something in their community. One student did volunteer work with a particular vulnerable population that wasn't on this list. And so she was very familiar with it and she did that. It was awesome. Okay, I think it's in week 7. Yeah. Okay, so your second group project is due in week 7. Okay, so that might be something, we're in week 4, so yeah, that's something you might want to take a look at it. It's infectious disease, right? So each group has to decide on an infectious disease. Let's see, let me pull you guys down here. Okay. So this is a group activity, but again, each student must submit their project under the name as a discussion post. This was it's the same as this last group project that you did. And so I got numerous emails. Where do we post it? Where do we post it? It's right here. It goes in the discussion post. It's considered group project discussion. Okay, so it goes in the discussion post. So each member of the group, you guys have to, each group has to decide on an infectious disease that comes from the National Foundation for Infectious Disease website. And here it is. So you need to go in and pick one. So let's see, we had hepatitis, HIV, what were the other ones? I think we had pertussis. You'll go in and see the list, but you guys have to decide on what you want to do. And then one member of the group will provide the name of the infectious disease to their instructor by week 4. Oh, that's this week. In the next week or so, if somebody could just let me know from your group which one you want to do. So if somebody wants to, somebody's going to need to take the lead in each group. Okay, so here's very specifically infectious disease paper directions. You have to name it, what's the cause, symptoms, you can go through this list, but all these need to be addressed. APA format, title page, here's all your instructions right here. APA references. All right, and again, everybody has to submit to get credit for it. All right, and I was lenient on the first group project. Most people did do peer reviews or peer responses, but it really wasn't specific. It didn't outline that, or I'm going to change the language for the next term, but here it's very clear. Okay, you have to post in this assignment, you have to post peer responses. Post to classmates. Okay, I want you looking at other people's papers and giving them feedback. Okay,
And we're with the same groups we were with for the previous project.
correct. Correct. And there's a method to that madness. The method is that if there were issues and struggles and group dynamic things going on in the first time around, now you have a chance to correct that and build on that, build on what you learned, and try and make it a more positive experience. Most groups did not have issues. It was great. But there were a couple of groups that did. So hopefully the groups that did will learn from what happened, maybe kind of regroup, have a meeting and decide how they're going to handle this going forward. Okay. So questions on both. Okay. It looks like most people are turning in their hospice case studies. I don't have anybody at this point that is telling me they have an issue.
For breakfast.
Excuse me? I don't have anybody that has an issue with case studies at this point. It looks like they're all uploading and there's nothing to submit to me. It populates right into the gradebook. Okay. And then we'll do our live attestation at the end of this class. And then for next week, we have a discussion. Okay, you have another discussion. So this is an upcoming week that you have a Wednesday assignment. Okay. All right. Okay, so those are the chapters we're going to be covering. I'd like to go through next week's just in case anybody has any questions. We have a discussion question. I'm just going through the module like you have. We have an NCLEX, okay? And here are your subcategories right here. Okay, there they are. I need 50 question batch. I can't accept screenshots. So you have to be starting the assignment through here. Let me go to student view. Right here, start assignment here. Don't do it from your outside computer, outside this module. It's not going to work. I cannot accept screenshots, and I cannot accept anything but a 50 question batch. I can't do 10, 10, 10, 10, and 10. I can't do 2 25s. I can't do it. It's not what the assignment is asking you to do. And I had both of that with the first NCLEX. Okay. I had a couple of people that did a couple of 25s and one person that did 5 10s. I can't accept that. All right. So 50, it's right here. Where is it? Select mode and 50 questions. Okay, and there's a reason why they want you to do 50 questions at one time, because it gives you a variety of topics that you've requested. If you do 10, 10, 10, 10, you don't get the representation. Okay, there is a reason that we want 50 at a time. Okay. Let's see. Okay, so we have NCLEX this upcoming week. And then our attestation. Okay. Questions? Okay, this week I'm teaching from the PowerPoints, and I'll tell you why. Because PowerPoints are always good, but we have 5 chapters to cover, and the PowerPoints are a good overview of what is in these chapters. So then after we cover these chapters, I want you to go back to your study guide. I've already, you got my little pretty color-coded study guide for chapter 2. It says which week the information is covered in. So if you're not understanding the information on the study guide from what I covered today, you'll need to go back in and do your own research, right? And get into the book and read about it if you don't understand what we're talking about today. Now, just a poll. I'm going to stop sharing for a second. Just a poll. I'm probably not going to see anybody. How many of you have taken a look at the PowerPoints for last week and for this week? Does anybody even know what topics we're covering? Anybody?
I did.
Okay.
Not to interrupt, but I think our professor is actually having her own Zoom, so maybe we should get on there. I don't know. I think maybe it was a confusion with all the Zoom links.
I'm confused. I thought
Yeah, I
that,
think
So-
Professor Apple is having her own Zoom right
She has
now.
her own Zoom right now, so
Yeah.
maybe I should be on there versus here, or does it matter?
that's totally up to you. I thought somebody said that
We
her
never got
session is not till 9
I
PM.
didn't.
What?
Yeah,
I
it's
never
not till
got the
tonight. She told, I
announcement that
texted, she said she's not having one till tonight.
But somebody just said she's having one now.
And I think somebody else is doing another piece right now.
Yeah, she
No,
looked
go
like
ahead,
she's
Pauline.
actually doing a Zoom.
If she's doing a Zoom now, and you can confirm that, I would go to her Zoom because she's your professor. So that's my guidance. You're more than welcome to stay here. But if she is actually doing one, probably best to transfer over to her. There is a student next to me in her class, and she is currently having a lecture right now. Okay, so Melanie, thanks for that update. Did you guys all see that from Professor Apple's class?
Yes.
Do you guys have a Zoom link for her?
No.
No. Then if you don't have a Zoom link for her, then just stay here.
I think they said she doesn't need a passcode, and someone put her Zoom link as 767-349-2403.
Okay. I don't know. I didn't know that I was going to have her students today, which is fine. I'm always happy to welcome students.
I just put her Zoom link in chat.
Okay, thank you. So whoever needs to jump out to go to Dr. Apple, that's perfectly fine. I'm going to keep going here. So the reason why I asked is who's had a chance to review these PowerPoints is because if you haven't, which the majority of you haven't, all this information today is new. All right, so don't be overwhelmed with it, but it all is brand new to you. So let's get going. So when we think of rural health and migrant health, what do we think of? What do you guys think of? What comes to mind?
Health risks.
Say that again.
Health risks.
Okay, what else comes to mind?
Rural would be like places where there isn't a lot of access, and migrant people who don't get a lot of access because of maybe their status or different factors.
Exactly.
Poverty.
else?
Sorry, poverty.
Poverty, absolutely. Absolutely. Okay, so in our introduction to rural care, we're on chapter 22. Right, the access is an issue. The scarcity of health professionals is an issue. Typically in the rural community, you may have one or two providers. There's certainly no specialty care to deal with, high risk pregnancies, specific chronic conditions, right? Migrant workers, right? Definitely an issue in the rural community. Pardon me, and we'll talk about that. Differences in rural versus urban. Significant differences in rural versus urban, right? Access, specialty care. But we do know that moving to rural areas is becoming a very, it's kind of exploding. More affordable housing, okay? What are some population characteristics and cultural considerations for rural populations? Okay, we know we have a higher proportion of whites, higher than average number of younger and older residents, more likely to be married or widowed, fewer years of formal education, and they tend to be poor. Okay. What would we think about the health status of rural residents? Do we think that they would be healthier or less healthy?
Less healthy,
And why?
because they have more issues receiving healthcare, whether it's financial
Yep.
or ways to get there.
Yep. So poor the rural community is not as healthy or considered not as healthy. Okay. One of the common factors you find, common health issues you find in the rural area is the prevalence of chronic disease. Okay. Chronic diseases. All right. They don't have access. They tend to have poorer health unless they less likely to seek medical care, right? Traveling may be an issue, transportation may be an issue, and they just simply have poor perception of their overall health, right? Health providers, right? You may have a nurse, you may be the rural nurse and do everything, be the labor and delivery nurse, the newborn nurse, the pediatric nurse, hospital nurse, immunization nurse, right? There's lots and lots of health shortages, health profession shortages in the rural area. One of the populations in the rural area that is very much affected by the environment is maternal and infant health. Okay, there's definitely higher infant and maternal morbidity rates. Why do we think that is? What do you think?
Less prenatal care.
Lack of education, lack of resources, and there are extreme variations in pregnancy outcomes. Okay, particular rural population, women populations that may be more at risk are women who live on or near Indian reservations, migrant workers, victims of sexual assault. And then we also consider the health of children at risk for the rural communities, right? They are much less likely to be able to see a pediatrician versus a general practitioner if they're ill, right? And the children that work on farms, their risks increase exponentially. That's why school nurses play a very, very important part of the health of the kids in rural communities. And then mental health is huge in the rural community. Okay, very high prevalence of mental health. Therefore, that could result in this population delay in seeking care, very high rates of depression due to poverty, isolation, and then the lack of resources of mental health services, domestic violence, alcohol, tobacco, and other drug use, very prevalent in the rural community. Okay, so let me stop and ask a question here. If you haven't reviewed the chapter, the information, you're not going to know the answer, but let's think about it. What happens in the rural community that might, what's the word? Prohibit or not have people report domestic violence, alcohol, substance abuse, severe depression? What goes on in the rural community that might prevent reporting of these kinds of issues? Anybody have any thoughts? 'Cause there is a-
Relations, small town relations, you know everybody.
Yep, perfect. Thanks, CJ. That's the answer. The lack of anonymity in rural communities really discourages people from coming forward with very significant issues. Okay, because the lack of anonymity, everybody knows everybody. Everybody knows everybody, therefore, everybody knows everybody's business. Make sense? Some occupations that create health problems in rural areas, specific, high-risk populations in forestry, mining, fishing, and agriculture. And there's certainly a lack of OSHA regulations for farming and ranching. Injuries are common. Why are injuries common? Big farm equipment, not wearing seat belts, right? There's just more of a laissez-faire kind of attitude in the rural communities. And because a lot of rural communities include agriculture, farming, there's a high risk of exposure to chemicals. Right. And then for rural health delivery, what are some barriers to care? All right. We've talked about it. Access, which is availability, affordable, lack of health insurance, accessible, acceptable services. Are there mental health services? Are there prenatal services? Are there pediatric services? Right. And same with professionals, right? Are the health professionals more of the general practitioner that don't have not any, but specific knowledge and specific areas, cardiology, neurology, right? To help with the chronic diseases, which are prevalent. Anybody that needs a cardiology or endocrinology or gastrology, anybody that needs those specialty services may have to travel significant amounts. And one of the biggest barriers to the rural community is transportation. So the nurse, the rural nurse plays a very, very important part in the health of the rural community. Very big part, from education to designing programs to meet whatever the risks of that particular community are. And you do that by doing your community assessment of the community, community assessment of the rural community. All right.
Professor Marvel,
Pardon me?
I was going to ask, isn't one of the also one of the reasons there's such a health disparity is that they have a lack of trust of outsiders, for what lack of a better word?
Absolutely. Absolutely. And this comes up here in the next couple of slides is when we're working with migrant families. How do you establish a trusting relationship with a migrant family who may be of a completely different culture than you? I think, Denise, that's what you're talking about. There's a lot of the same barriers and health issues with rural populations and migrant farm workers, but there are some differences as well. So let's talk about migrant farm workers for a minute. Characteristics of them, they're different cultures, they have different lifestyles. And this next one is issues in migrant health, slide 15. A lot of these are also issues in the rural community, but are overlapping with the rural community, but some of them are specific to migrant health. Okay. Cultural aspects is really important, right? If we don't understand their culture, then how are they going to trust us to help them with their needs? Right? Transportation, we said, was an issue. Availability of services. So a lot of this we just covered with rural. With migrants, there may be increased language barriers, discrimination, cultural differences. Okay. Lots of issues, lots of barriers in the rural and migrant communities, right? So here's what Denise is talking about. Cultural considerations for migrant healthcare, the nurse-client relationship, and the health values, beliefs, and practices. And we'll talk about this a few other times today, but we need to check our own values and check our own beliefs and check our own cultural sensitivity to different groups, right? Migrant and rural populations have issues with trust. Okay, how do we develop trust, a trusting relationship with an individual, a family, a community, rural migrant that we might be working with? Really important stuff. Denise, is that kind of what you were talking about?
Partially, but I also mean a lot of very rural communities don't tend to trust anyone that isn't part of their core group of people.
Right.
And because of that, they don't tend to go and like ask for help. They don't believe that you should do that.
Right. That's what we just talked about a few minutes ago with the lack of anonymity, that they are a very close knit community and they are much less likely to report issues, right?
Right.
Report issues of domestic violence, report issues of substance abuse, report issues of mental illness, because they're a very close knit group and they don't want everybody knowing their business.
Right.
And you're actually, there is a question around that topic on exam 2.
Okay.
All right. Regarding why, what is the reluctance of families in the rural community, migrant community to come forward? They don't want to, they want to just be in their own little pod. They can solve everything on their own.
Right.
And they don't want outsiders. Right?
Correct.
Okay. All right. Nursing care. What might our nursing care look like in rural environments? Well, the needs are in the rural school nurses, family planning services, prenatal care. Here's the whole list. And we as the rural nurse could be doing one or all of these. Rural nursing and migrant nursing, the nurse is the expectation is that you have a very wide body of knowledge. You're bringing in all your skills because you're caring for people across the lifespan, right? You're caring for babies, school-age kids, adults, elderly, right? So rural nurses require a lot of pulling together everything. It's not your pediatric patient on the pediatric floor at the hospital with asthma. Okay, that may be one day. The next day in the rural community, you may be dealing with chronic illness in an elderly couple. Just depends. Okay. Case management is important in the rural community. What is case management? You are coordinating care. All right. So case management, right? A lot of these families are going to need to be case managed because they're, for whatever barriers they may face, cannot figure out what resources are there for them. Right. And you're going to have to help them coordinate. If they have health issues, do we need to get them down to the cities for this? Do we need to get the kids that are not performing well in school assessed for disabilities? There's a lot of case management that goes on in the rural community, right? And then Healthy People 2020. Right? You can go back to chapter 22 and look at the Healthy People 2020 box and see what objectives they have for rural and migrant populations, right? So go back and do that. Okay. And then obviously great potential for connecting rural providers and consumers with resources outside the community. And that has definitely increased. Especially over the last year and a half, 2 years with the pandemic, is that we are relying on telehealth, video conferencing, and that has really helped the rural community be able to tap into the urban resources of specialty healthcare. So questions about, that's rural and migrant. Questions about that? Okay, the next few chapters are kind of rough. because we're talking about significant vulnerable populations. Okay, so it's hard. Okay, there's probably not one of us in this group that hasn't, there's probably not one of us in this group that hasn't dealt with any of these: poverty, homelessness, teen pregnancy, mental illness, with ourselves, our family members, our friends, our coworkers. Okay, we all know somebody who either is or was considered a vulnerable population. And for purposes of this chapter, we identify four groups of people who represent members of the vulnerable population: the poor, the homeless, pregnant teens, and those who are mentally ill. These four groups present complex nursing needs. Okay, there are many other vulnerable populations. Okay, but for purposes of this chapter, that's what we're focused on. Okay, so we need to understand our own beliefs about these groups. This is similar to what I just said about rural and migrant nursing. What are our own beliefs? How do you feel about homeless people? What do you think when you walk down the street and see a homeless encampment? Are you judgmental? Are you empathetic? I mean, we all have our own beliefs and our own values and our own thoughts, but we need to come to grips with those if we're going to be caring for these kinds of vulnerable people. And know that whatever kind of nursing you decide to go into, you will take care of these patients, clients, right? You will. You are at some point, you are going to be caring for these patients, whether it's on the street or whether it's in the hospital or whether it's in the urgent care or whether it's in the homeless shelter. So vulnerable population, it's hard, right? But we need to understand our own beliefs about these groups, right? We need to understand what the healthcare needs are, what their barriers to care are, right? And what are the essential services for each of these groups? That's why you're going to be doing your vulnerable populations assignment. Okay, that's what this course is really built around, is how do we have a healthy community? How do we strive towards a healthy community? Well, one way we strive towards that is identifying who our vulnerable populations are and trying to work with them, okay, to move towards a healthier community. All right, so attitudes, beliefs, and the media, right? What cultural attitudes, right? Perspectives about individual responsibility for health and well-being, right? They're influenced by our cultural attitudes. The media, think of the role the media plays in the way we see these kinds of four particular vulnerable populations. You consider your personal beliefs and attitudes, perceptions, social, political, cultural, environmental factors influence the client situation. So let's stop for a minute. I just want to see what you guys think about that. What do you guys think about these populations? Anybody work with these populations?
Just the experience of having them in the hospitals. There's always somebody that's in it. It's, I mean, one of those populations.
Yeah.
I did 8 weeks in Texas doing the COVID vaccines for homeless camps. And I do rounds with the homeless going into camps for delivering food and medical.
And so what advice would you have for your peers, Barbara, if they decide they want to work with the homeless? What attitudes do you have that make you successful in working with this population?
they're all people. I mean, they're just like you and I.
Mhm.
I mean, they're no different than anyone else. I mean, that's just my attitude. There's no different than you and I.
I work for a psychiatrist.
Okay. So you work with the mentally ill.
Correct.
So what are your attitudes and beliefs that make you successful in working with this population?
Just like Barbara said, but I have a very empathetic attitude towards them, knowing that, it's not their fault. They don't act that way or come off that way intentionally.
Thanks, Quinn. Anybody else work with vulnerable populations like this? Okay, so then we go through a few of the slides for each of these populations. So poverty, we all know what poverty entails. We talked about in week 2, when we did weeks 1 and 2, that poverty, economic stability is the driving force for most, right? Poverty dictates food and nutrition, healthcare, standing in the community, access to resources, right? So here's some factors affecting the growing number of poor persons, right? Obviously, decreased earnings, unemployment, changes in the labor force, adequate education. Okay. And we know that poverty and health and the effects across the lifespan, chronic illness, higher infant morbidity, mortality, shorter life expectancy, more complex problems. All right, hospital rates are going to be 3 times higher for persons that are in poverty, right? Because they don't have access to care. Right? Here's some especially vulnerable populations with the effects of poverty: women of childbearing age, adolescent women, children, older adults, both urban and rural communities. Okay, homelessness, understanding the concept. Well, we know that obviously poverty can lead to homelessness. Right? And it's hard to know exactly how many people are homeless. There's a few ways to look at how to determine the number of people that are homeless. Is poverty with the individual or family or the community? Is it a crisis? Is it a crisis poverty situation where they just down on their luck and it's a temporary situation, or is it persistent poverty? And I'm talking now whether we're looking at an individual, a family, or a community. Okay, what are some effects on homelessness on health? Hypothermia, infestations, skin integrity. You can read through these. Okay, mental illness is huge. Use of alcohol, tobacco, and other drugs, huge with the homeless population. Homeless at-risk populations. Okay. Pregnant women, homeless at-risk populations, anybody who's homeless that's pregnant, children, adolescents, older adults. Okay. And then we look at teen pregnancy, right? What do we know about teens and pregnancy? Okay. They are at higher risk for violence. They are at higher risk for poor birth outcomes. They are at higher risk for sexual abuse. it is critical when you're working with a teen pregnant client that you identify any issues, identify what issues are going on in their pregnancy, especially if it's anything to do with violence or abuse. Okay, so violence, nutrition, infant care, schooling and educational needs are 4 different areas that we want to focus on with the pregnant teen. And if that means every time they come in for their appointment, we discuss the relation, discuss their relationship with with their partner. We discuss their nutrition. We prepare for an infant. Okay. Teen pregnancy has a lot of risks. Okay. And then mental illness, the 4th group. Mental illness is huge. Right? At-risk populations, again, children and adolescents, adults with serious mental illness, older adults, and cultural diversity affects mental illness. Look what's happened over the last 18 months with mental illness with these kids, children and adolescents. And I'm living and breathing it with school-age kids. The mental health issues are exponential what they were 2 years ago. The suicide rates are through the roof for kids. So with these 4 vulnerable populations, let's look at what some primary, secondary, and tertiary prevention tasks could be. Okay, what's primary?
Teaching.
What?
We're teaching.
Okay, education, prevention, teaching. So what could we do for these populations? Affordable housing. We're trying to prevent things from happening. Housing subsidies, effective job training programs, employer incentives, and so on and so on. Safe sex education, needle exchange programs, right? Prevention. What's secondary?
Early screening.
Yeah. Aimed at reducing the prevalence. Okay, so supportive and emergency housing, soup kitchens, screening for depression. So you're screening these at-risk populations to see what resources they may need initially to try and prevent them from being homeless, try and prevent them from suffering from a mental illness, right? We have identified them as high risk. Now we're trying to head it off before they actually suffer from one of these. And then tertiary, what does that mean?
It's like people with chronic, like somebody who has a chronic illness, and we're just trying to help them maintenance, basically.
Exactly. Thanks, CJ. Tertiary is management of the chronic disease, management of the issue to try and prevent it from getting any worse, try and prevent complications or, effects getting any worse, right? So it attempts to restore and enhance functioning. All right. So if they're homeless, we want them not to be homeless. If they have a mental illness, we want them to be to have that managed. Okay. If they're a pregnant teen, we want a successful birth and thereafter successful new parent. Make sense? And then what is the role of the nurse with all of these vulnerable populations? Trusting environment. These vulnerable populations are very, very on edge. They're very compromised. Okay, so you must find a way to create trusting environment. You must find a way to check your own beliefs and values and be able to show respect and compassion and concern for this population. You can't make assumptions. You need to, if you're the community nurse, you need to have a whole network of resources and providers that you can be able, you're able to refer these different kinds of vulnerable populations to. You need to know the resources in the community, right? Obviously, we want to focus on prevention, right? We would like for people not to become homeless. We would like for teens not to become pregnant. We would like for mental illness to be in check, right? And then we need to practice our role of knowing when to, walk beside the client and when to encourage the client to walk ahead. And then lastly, develop a network of support for yourself. So these vulnerable populations are very, very emotionally challenging for us to work with day after day after day, right? So we need to try and develop a network of support for ourselves, the caregivers. And I would take that into the families. If you're working with a family, you need to develop a network of support for yourself when you're not only dealing with the individual, but you're having to deal with the whole family who's dealing with substance abuse of an adolescent or suicide ideations of a high schooler, right? This is hard stuff for the community nurse. So you have to develop a network of support for yourself. Okay. And then that goes right into the next chapter, which is alcohol, tobacco, and other drug problems in the community. And again, I guarantee you, every single one of us, whether it's personally, family, friends, workplace, or have been involved with somebody that's had issues, addiction issues. Okay. I was telling the group yesterday, of my 4 kids that are ages range from 27 to 32, 26 to 32. Anyway, 3 of my 4 kids have had friends that have died of an overdose. 3 of my 4 kids.
I think it's a lot more prevalent than people realize.
Absolutely. What do you guys think, before we talk about this chapter, what do you guys think about this chapter, alcohol and drug abuse?
I think it's ignored. I think drugs are very, very much a problem in the children, the teenage years and whatnot. And I think everybody overlooks it. And I think it's very, very sad. And I didn't realize it until my son reached that age. And he said, Mom, they're everywhere. He said, you don't go to a party without drugs being there. And nobody does anything about it. Nobody.
I agree totally.
I think
They
it's
glamorize it. They glamorize TV and culture. They really glamorize the use of drugs, like you can start and stop at will. They never tell you the addictive power of it, or they don't show it, and they never put it on TV just how terrible they are. They just make it look so like, oh, you're gonna have the best time of your life and you'll go on and nothing will happen.
And to piggyback, I think we're going a long ways with like mental health awareness and these things, but I notice a lot of people, if you haven't had family that's like, or maybe if you have, I don't know, but that's had to deal with the drug addiction and that, they're not very understanding. It's kind of like it's a flaw in character, which is unfortunate because I don't know any drug users that's what they wanted to do, before they were drug users, and I know a lot of people or several people that are good people that are just, in a bad place. And it's, to me, I mean, I look at it like just another mental health issue.
I agree with that because I thought that before I learned more about it, through school and whatnot. And I would always think, well, that's their fault. Why don't they just stop doing drugs? Or, they got on drugs intentionally or whatnot. And the more I learned about it, the more I realized, oh, they got addicted to drugs after a surgery or whatnot. And it's not necessarily their fault. So my viewpoint has changed on that. So I absolutely agree with that statement.
Anybody else want to jump in?
This is Shaw Niece. I've had a lot of experience, but first I need a preference. I'm a psychotherapist, so I'm not coming from that standpoint. I'm a student in saying this. With the adolescents, whether they are preteens, you'd be even surprised at some as early as 9 years old, those to 19. I'm thinking of a case right now that I had a male Caucasian being raised by his grandparents, both parents heavily poly substance dependent, basically raised himself, came to do very well, but had a lot of trauma, a lot of substance abuse itself. Having that background, what you'll notice is in my working directly and indirectly for 21 years with these various populations, but since we're dealing with the adolescents, I'll talk about them, is that it's tied to a lot of trauma, a lack of a consistent, healthy support system. They are knowledgeable about resources. However, the addiction is psychologically stronger, and it is more of a what is habitually worked for me just to get that quick quote unquote say fix of not having to have these constant traumatic or PTSD experiences running through my head. Let me go take this hit. Another thing with adolescents, I'm not sure if everyone knows, but you hear a lot of adolescents talk about 420. And what they're talking about is April 20th. April 20th is a national, basically kind of sort of day where you'll see a bunch of high school students, especially, that will skip school. They have parties. You've probably heard of those now that they have, where everybody kind of brings the prescription drugs now. The marijuana is still used. There's I had an adolescent that had marijuana, did not realize it was laced with LSD, almost lost her life.
Yep.
So just a few points. I could go on and on, but like I said, I'm just sharing that. This is not me talking as a therapist, so I just want to preference that.
Yep. Thank you, Shanice, for your input. I appreciate that. It's
No problem.
very important to the discussion. We do know that alcohol addictions and drug addictions are the #1 national health problem, right? We know that people who abuse alcohol and drugs, they're much more at risk for other personal health problems, right? But they may be a threat to to health and safety of family members, coworkers, and other members of the community. And this gets into workplace violence, school violence, right? How many seen a lot of that, right? So we know that for the purposes of this chapter, alcohol, tobacco, OD is other drugs, alcohol, tobacco, and other drugs, right? Causes multiple health problems for individuals. There's always contributing factors, meaning there's a gazillion reasons why it might be triggered. Okay. Every situation is different, right? And then every culture has beliefs and attitudes towards this, alcohol and tobacco and other drugs, right? We just talked about drug addiction, alcoholism, drug dependence, substance abuse, just some of the terminology. And then I'm going to have you guys review slides 6 through, I think it's 17 on your own, because these are, I don't want to go through all these. These are just the different kinds of drugs that are discussed in this chapter. Psychoactive drugs, antidepressants, stimulants, okay, alcohol, tobacco. It even talks about caffeine, heroin, most often recreational used opioid, right? Tolerance and physical dependence develops quickly, right? We all know what happens. Heroin overdoses, they're everywhere. And like Shanice said, now the issue is all these drugs being laced with other drugs. And I know that a lot of overdoses are unintentional. I get that. Talk about marijuana, you know, states who legalize marijuana, everybody has their own opinion. Is that good or is that bad? Hallucinogen drugs, inhalants, right? Predisposing contributing factors. I don't know. I mean, it's anything, right? What are the predisposing factors? Is it hereditary? Is it not hereditary? Is it peer? Is it peer influence? Is it a traumatic event that happened in your life? What triggered it? Okay, what are some primary, the next 3 slides, 19, 20, and 21, we need to know. Okay, these are primary, secondary, and tertiary prevention strategies for this group, right? Primary, promote healthy lifestyles, promote education about resiliency, right? Good health, dangers to drugs, good nutrition, risks of obesity, maybe drug education for our kids, right? And teaching kids that no drug is completely safe and that any drug can be abused, right? Talking about peer pressure. Okay, secondary, we need to try and do an assessment of who's at risk. Here's some high risk groups: adolescents, older adults, injection drug users, drug use during pregnancy. These are the groups we need to work with. These are the groups that are at risk, right? We need to assess for these kinds of problems with these at-risk groups. Maybe drug testing, codependency and family involvement. Okay, we need to assess for that. So we're trying to screen who our at-risk groups are and try and work with them before it develops into a full-blown addiction. And then tertiary, they already have whatever addiction they have. Then we have to look at detox, treatment. If it's tobacco, smoking cessation programs. What kind of support groups are available? Well, you have your AA, your Al-Anon, your narcotics, your overeaters, gamblers, right? And what's our role? Right? We need to be, community nurse again needs to step up and be knowledgeable about the community resources and how to mobilize them. Developing community prevention programs. That's part of the primary role, primary intervention of the community health nurse, prevention programs, right? And then we play a role in all 3, primary, secondary, and tertiary. Nurses are an ideal role to assist with tertiary prevention, for both the addicted and the family. It's tough. But community nursing, we're in the community. We deal with this all the time. We deal with vulnerable populations in the community all the time. And this is a vulnerable population. Okay. Questions about that? Last couple of chapters. It's tough stuff. It's tough stuff. But, you know, we as a society are much more diverse, and we are dealing with much more serious problems, right? Health, physical health, mental health, poverty. We are going to be working with all these kinds of populations in the future, or you will be. You probably already are. You might already be doing that in your current work environment. You might have personal experience with it. Vulnerable populations are not going away. They are increasing, actually. The challenges are increasing. Okay, when you guys think, moving forward, what do you guys think a faith community nurse does? Parish nurse, what do you think they do? What's their role?
Incorporate faith-based health with medicine, I think.
Mhm. Right. So, faith-based nursing and parish nursing are synonymous. So we're going to, and faith-based nursing can be wherever you practice nursing, or wherever you practice, whether it's a synagogue, a mosque, a cathedral, a church. All right. So parish nurses, faith community nurses, parish nurses work in close relationships with individuals, families, and faith communities to establish programs and services that significantly affect health, healing, and wholeness. Okay, we talk about health ministries. A lot of times the parish nurse, whatever faith community you're working in, falls under the health ministry, right? Faith nurses balance knowledge and skill in the role and facilitate the faith community to become a caring place, right? Faith community nurses address universal health problems of individuals, families, and groups of all ages within their faith community, right? Faith community nursing is gaining prominence as nurses reclaim their traditions of healing, acknowledging gaps in service delivery, along with the rise in nursing centers. Okay. What are the definitions of faith community nursing? Here's where it's wherever you practice, right? Faith communities are groups of people that gather in churches, cathedrals, synagogues, mosques, and they acknowledge their faith, right? Parish nurses, faith community nurses are typically respond to health and wellness needs of the population of faith communities, right? And they're partnering with the church to fulfill the mission of the health ministry, right? So depending on what their role is dependent upon what the goals are in the overall of the health ministry. Some of the things they might do: visiting the homebound, visiting parents of newborns, providing meals for families in crisis, developing a health fair, blood pressure screenings, participating in prayer circles, volunteering in the community, right? Grief support groups. Make sense? And we do need to know slide 5. There's 2 models of faith community nursing, and this is the first attestation question. There's a congregational model and the institutional model. Okay, so in the congregational model, the faith community nurse is responsible to the congregation itself. Okay, he or she is part of the development of the health ministry program that is derived from the needs of that particular community. right? She's accountable to the congregation. Okay. If the role is the institutional model, then they have taken it a step further and requiring maybe care for the ill congregation members in the community. Okay, and that faith nurse can't do everything. So they may have to partner, collaborate with outside agencies to provide maybe healthcare. You know, if she's only doing if she's from the congregation, if she's only doing the new parishioners visits or the newborn visits, well, what about if you have other parishioners that might need OT, PT, home health, whatever? And that's not part of their strategy, then they move into the institutional model where they have collaboration and partnerships with the community. All right, they may have to partner with a home health company, long-term care center, PT company, OT. Does that make sense? To meet the needs of the community. So the congregation model is specifically functioning within the congregation. Institutional is you've decided to meet additional needs of your faith community, but you will have to contract and partner and collaborate with outside agencies to make that happen. Okay, we don't need to review historical perspectives, right? The important thing to remember with the faith community nursing practice is it's the spiritual dimension that becomes a central practice of parish nursing. Okay, the ADPI is definitely applicable here. But we need to add the spiritual dimension. All right. Parish nurses, faith community nurses are more focused on health education, teaching. Right. And then faith community nurses have their own scope and standard of practice. Right, health promotion within the context of the parishioners or the faith community members' values, belief, and faith practices. Okay. And again, just like a hospice nurse or a home health nurse or a school nurse or an occupational nurse, you have a professional nursing code of ethics. Does anybody know any faith nurses? I do. They're like angels from heaven.
I
No,
work
but I
at
was.
one called a Reiki nurse. Have you ever heard of that?
Mm-mm.
It's something similar, I think, because they did like the whole body, and the spirit healing kind of stuff. But it was very fascinating to learn more about.
Yeah, yeah.
This sounds amazing. I would love to be one.
Yeah. My girlfriend does. She's been in the same parish for 30 years. She's like, I mean, she loves it. She's perfect for it. It's just a joy to watch her perform in her role. It's really cool.
I
Okay,
know,
so
I know, like they do like Reiki therapy and stuff. I know a nurse that does like they use a lot of scents, and she worked for the VA for a lot of years. And she does like aromatherapies and then touch therapy. And she does Reiki, and she does banding. She uses different pressure bands and she puts them on different areas of the body. And they're just different types of bands to, you know.
Right. And depending on what the community needs are and the roles that they want as part of this health ministry determines what kind of services they provide. So yeah, lots of different services they provide.
I think this is very interesting. I'm a certified Christian doula, but I can't use my nursing in my doula world.
Mhm.
I mean, I could do certain things, like I could do, blood pressures and, whatever. But I can't, my roles, because I'm an LPN, my roles can't really combine. But I would love to be able to take my nursing role and combine it with my faith. So this is very, very interesting to me.
Yes, yes. And faith community nursing is really I mean, it's always been around, but it's getting a lot more attention and focus recently, in the last 5 years. So it's really fascinating. It really is.
Yeah, I'm gonna do more research on that.
Yeah. I want you to review 10, 11, and 12 on your own. We're going to have these slides in this chapter and the next chapter. So in faith nursing, you're going to have ethical issues. Okay. So I want you to read the slide about ethical issues that may arise in faith nursing. And then we might have legal issues, just like we would do in the hospital or another nursing setting. Faith community nursing is not immune to ethical issues. I mean, think about end of life issues. Right? So you're going to have ethical, legal, and financial. Okay. So read through those. Okay. So, functions of the faith community nurse. Here's some common functions. Personal health counseling, lots of health counseling, actually. That could take the form of health risk appraisals, spiritual assessments, plans for healthier lifestyles. Right? There are also other functions, health education, liaison, facilitator, pastoral care, services to the vulnerable population. That's just a beginning list. And again, it all goes back to the needs of the community, the faith community. So that is our faith chapter. So we've now covered, there's lots of hats a community nurse might wear. We have covered school nursing, right? We've covered faith nursing. We're going to cover home health and hospice now. I think next week we cover occupational therapy. So occupational nurse, right? So there's lots of different aspects of community nursing that we can be a part of. Okay. So with regards to home health and hospice are used interchangeably in this chapter. Right. So we know that home is a place where nurses have provided care for more than a century. However, we know that home care has increased significantly over the last 10 years. We are doing so many procedures and so many health tasks in the home that used to be done in the hospital. Can you guys give me some examples? What's done in the home now that
IV therapy.
IV therapy, absolutely. What else? What about wound care?
Yeah.
Mhm. What else? Anybody work in home health?
I do.
What kinds of things
I
do you
work in
do
home
that?
health, go
What?
ahead, behavioral health. Home health, behavioral.
Mhm. All right, so we all know it's factual that people would prefer to be taken care of in their homes, right? Home care gives clients and families a chance to receive health care in their usual home environment where they may feel more comfortable and where it may be easier to learn how to make health-related lifestyle changes, right? And then for clients who are homebound, home care is all they have. Okay, and what does home care include? Disease prevention, health promotion, episodic illness care, right? It's an approach to care that's provided in people's homes because theory suggests that home is the optimum location for certain nursing and healthcare services. Right? And when we're doing home care, we're also doing family caregiving, right? Because we are also responsible for working with the family that's also caring for the client when we're not there. Right? So we are teaching and supporting family caregivers for basic needs, right? Meal preparation, personal hygiene, medication, treatments. We may be educating and teaching all the caregivers about that if they're the family members, right? Working in a client's home, right? Nurses, home health nurses are very autonomous, little structure, little oversight. That's why we have our standards of care and scope of practices. Okay. When working in a client's home, the nurse is the guest. And to be effective, you need to earn the trust of the family and establish partnerships with the family. And obviously, client safety needs to be your utmost concern, just as it would be in other healthcare settings. Okay, this is the second attestation question. There's five models, practice models of home care. Okay, we have our population focus. We need to know these. They're on slides 8 and 9. Okay, population focused home care. You can read through these. All right, I want to read the first one. Population focused home care is caring for a specific group in your community, maybe those with high risk health needs, such as the population in your community with mental health issues, cardiovascular disease, diabetes, right? So your specific population, right? Transitional care is clients going from one level of care to the other. Maybe they're going from assisted living to long-term, or hospital to rehab, or rehab home. Transitional care, home-based primary care. All right, this is for people who can't get out of their homes. Difficult for them to get to the clinics or community center due to whatever barriers they have. So it's home-based primary care. And then we have our home health, right? Which different aspects of home health. I just need you to know that home health is one of the 5 practice models. And then we have our hospice model, which is palliative care of the dying. And then we all have our scopes and standards of practice. Okay, so we have our direct care and we have our indirect care. Okay, so 10 and 11 we need to know as well. Right, so direct care refers to the aspects of nursing care that are direct care, anything that requires physical contact, face-to-face interactions. Changing a dressing, giving a medication, inserting a catheter. And what are our indirect care activities that the nurse does on behalf of the client to improve their health status? Consulting with other nurses and health providers on maybe approaches to care, conferences, advocating for client with a healthcare system and insurers, right? What if there's a new drug out there that maybe your client doesn't have insurance for, but you know that if they could take this drug, it would help. You've done the research, you've done the studies, it would help them dramatically. Can you advocate for the clients and talk to their insurers and plead their case? Yes, of course. So that's what you need to know with home health is you can be a direct caregiver, but you also have indirect care activities that you should be participating in. Okay, what are some of our roles in home care? We could be one or all of these, depending on where we worked. The direct caregiver, case manager. So this is your direct caregiver, your client advocate, your indirect educator, mentor, researcher, researching a new drug that might work for this client, administrator, consultant. And then again, we talk about scope and standards of practice. There is a code of ethics for nurses. There are specific standards and scope of practices for home health, and there are specific scope and standards of practice for hospice, as there are for school nurses, as there are for occupational nurses. Okay, so you need to be familiar with those. Okay. Quality management is in the community care, just like it is in the hospital, right? Evidence-based quality performance improvement, right? That happens in the community, that happens in home care. Same thing in the hospital you would do. There's nothing in this list on this slide that you wouldn't be doing in a hospital, right? Monitoring care, seeing and analyzing opportunities for improving care. Again, I'm asking you to transpose your ADPI into this setting, into the home care setting, into the hospice setting. Okay, this is all your ADPI right here in the community, in the home health community setting. Right? And then just like the hospitals, there's accreditation. Okay, for home health agencies and home care visits. Who hasn't prepared for an accreditation visit wherever you work at some point? It's crazy. And then again, I'm going to have you read through 19 and 20 because there are legal, ethical, and financial aspects of home care. Reimbursement issues. What's the difference between Medicare and Medicaid? Okay. Financial, the cost effectiveness. Because of the increased number of home health agencies and increased costs, right? There's all new prospective payment system programs going back 20 years. Okay. And then there's legal, just like there is in a hospital setting, legal and ethical issues, right? Negligence, malpractice. Again, just like the hospital setting, this can move into the home setting. Okay. So that's our nurse and home health and hospice. And just because I skipped through these pretty quickly, because I wanted to cover all 5 chapters, doesn't mean that you shouldn't go back and review these PowerPoints. Because these PowerPoints from these 5 chapters are in your study guide. Okay, parts of each PowerPoint are in your study guide. Okay, so we covered a lot today. We covered significant vulnerable populations. We covered faith community nursing. We covered home health and hospice, which are used interchangeably. Okay, but there is information on your study guide about hospice nursing with a few scenarios that you need to read through. Okay. Before we go to attestation, questions, comments, helpful, too much information, where are we at?
I'll definitely need to go back through it and
Yeah.
pull out more.
Yep. And then next week we have week 5, and then that's it for exam 2. Okay, so we have this week, which covered weeks 3 and 4, and then next week, week 5, and that's it. And so next week at this time, you're going to be going to review sessions for the following week, for week 6 for an exam. Next week is week 5. So we're humming right along here. Questions? Anybody? Does anybody have any questions? Let's go to our attestation. Everybody move to attestation. We'll try and get this done now so you don't have to think about it. And I believe the first attestation question is name the faith community models. 2 faith community models. What are they?
Congregational and institutional model.
Okay. Can anybody tell me what a congregational model is? No? Okay. If somebody wants to put it in the chat for the rest of the group, that's fine. Does somebody want to tell the group what an institutional model is?
Sorry, I was writing. So a congregational, would that be like that's a specific organization, like say the Catholic or the nuns or something? Is that what a congregational would be?
Congregational model means that you're providing healthcare within the faith community only. Okay, so it's whatever faith you're in, you're just dealing with the congregation. But if the health ministry has decided to expand services and you need to partner out, collaborate with other services in the community to provide care, then that becomes the institutional model.
Okay, thank you.
Does that make sense? And then your second question of what are the 5 practice models for home care? That was on 2 of your slides. Anybody want to go back and look at what those are? Let's start with the
population focused home care, traditional home care in the home, home-based
transitional. Yep.
home-based,
What's the
home
5th?
health and hospice.
Perfect. And you need to know those. That's essential knowledge. Your 2 parish model practice models and your 5 home health practice models. You need to know that. And that should be on your study guide. So as soon as you're finished with that, you can hit submit and you're all set.
Thank you,
And so,
Professor.
you're welcome. So I'm done with this lecture. And so I'm going to stop recording.